Hello, everyone. Welcome to the Pediatric Brain Tumor Foundation's webinar. Our program will begin in about a minute. Okay, I know we have people filtering in, but we're going to start our program. Hello, welcome to the Pediatric Brain Tumor Foundation and the Coalition Against Childhood Cancer's webinar, Medicaid Under Pressure, Supporting Families Through Policy Change. My name is Mike Henry, and I am the Director of Advocacy for the Pediatric Brain Tumor Foundation. Thank you for joining us today for this important subject. Before we get started, I have a few guidelines to review. You are muted for this webinar and your video is disabled, but we welcome questions during and after the opening remarks. Please type your questions into the Q&A feature found at the bottom of the Zoom window. We will not get to every question, but we'll try to answer as many as possible. Misha?
Good afternoon, everyone. Good morning. I am Misha Mehta. I'm a scientist by training, a devoted mom to my beloved brain tumor angel, Neve, and a passionate patient advocate. I bring over 15 years of experience in biopharma, clinical research, and rare disease advocacy to my work, which is deeply informed by both my professional as my personal experience. I am also a proud co-founder of the Neve Colte and the Brave Ronald Foundation, and I serve on the board of Coalition Against Childhood Cancer, where I lead the educational and the webinar series. Today, in partnership with the Pediatric Brain Tumor Foundation, we are honored to present this critical and timely webinar on Medicare and the pending changes as it impacts children with cancer. At CAC2, we always begin by reaffirming our core values, putting children and families first, respecting every organization and individual in our community, striving for efficiency and inclusivity, amplifying our impact through collaboration, and staying action-oriented and flexible. These principles are not just words, they are the foundation of everything we do. With that, we are pleased to welcome our speakers for today's webinar. Dr. Sharon Castellino is a professor in the Department of Pediatrics at Emory University School of Medicine, both certified in pediatric hematology and oncology. Dr. Castellino is the director of Leukemia and Lymphoma program at the AFLEC Cancer and the Blood Disorder Center of Children's Healthcare of Atlanta. She is a member of Cancer Prevention and Control Research Program at the Winship Cancer Institute of Emory University in Atlanta, Georgia. Our next speaker is Ms. Ashley Timmons, as the parent of Ophi, a current pediatric brain tumor patient. The Timmons benefit from Medicare as their secondary insurance and will talk about their experience with the program. And a final speaker is Ms. Mariela Kress, serves as a senior health advisor to the Senate Finance Committee. Prior to her work in the U.S. Senate, Maria served as an advisor at the Center of Medicare and Medicaid Services, a director of federal advocacy at the American Academy of Pediatrics, and an executive director at NYC Care, a $100 million healthcare access program that guarantees low income and no cost services offered by the NYC Health and hospitals to the New Yorkers who do not qualify for or cannot afford health insurance. Thank you.
Yeah, we have a great lineup today, and I'd love to kick things off by introducing Dr. Sharon Castellino to share clinicians' view of Medicaid and the program's importance to the patients they serve. Dr. Castellino?
Hi, thank you. Are you going to share my slides, Mike?
Yeah, Alex is pulling them up right now.
So thank you for the opportunity to be here and reflect on a physician's perspective. And I will say that some of my understanding of Medicaid policy as it currently exists and of the uncertainty of what's to come with potential changes is really informed by one of my health services research colleagues, Dr. Zhu Ji, whose name you'll see on some of these slides. What I want to say is that we address supporting families through policy change is that most physicians actually aren't always fluidly aware of Medicaid policy, but they rely heavily on their teams, including social workers and case managers. And you might have experienced that in most of your centers. Next slide. We just wanted to review for relevance that the timing of insurance enrollment and the continuity of coverage influence of any kind of insurance influence outcomes along the spectrum of care for pediatric cancer patients. And that starts with prevention, detection, diagnosis, and then treatment with chemotherapy, radiation, or surgery, and then into the survivorship period, which is really lifelong after treatment and survival for childhood cancer patients. Next slide. And so, next slide. So when we think about this, context, I think we have to regard how we think about insurance for children. Medicaid, as many of you in this audience know, is the largest insurance program for low-income and disabled people in the United States. And while the healthcare system funds apparently approximately 80 million individuals, the single largest insurer, Medicaid is the single largest insurer for youth, covering about 37 million children a year at this point. At cancer diagnosis, about 40 to 55% of children come in having Medicaid. That's estimates from centers around the US. And so that number may vary on either side of that window. At the current time, Medicaid eligibility is for children from families with low incomes, children and their parents, but they can be regarded separately, and that's something we'll make a point of again and remember. It also insures people with disabilities, which children with cancer in certain phases of their therapy count in that category as well. And then pregnant women and those eligible under the Affordable Care Act in states that have regarded Medicaid expansion. Next slide. So as you can see from this map, the majority of states in the country have adopted Medicaid expansion over the last few years. And in those states, in general, they cover patients, adults who are at living in families that are at 138% of the federal poverty level, which you can see defined there in the left corner of this slide. In non-expansion states, Medicaid covers parents, and the variation of the criteria really varies across the states. And you can see a lot of those states are concentrated in the southeastern US. And it typically does not cover adults without children. In addition, there are some waiver programs that vary by states, and some of you may be familiar with these programs called the Katie Beckett programs, which are options for children less than 19 years of age with significant disabilities or complex medical needs. And in these cases, the eligibility for a period of acute illness can be regardless of family income. Next slide. So the timing and continuity of Medicaid coverage matters. Many previously uninsured patients do not receive Medicaid coverage until the point or after a cancer diagnosis, and we see that not uncommonly. So that that number that I showed you earlier doesn't fully account for a few patients who come in without any insurance and then can gain Medicaid right at the point of diagnosis. These delays for families sometimes, or this lack of coverage initially, can delay access to primary care and preventive care services. It has missed opportunities for earlier detection of disease in some cases. And then we also have data that showing that patients who didn't have coverage ahead of time may present at a later stage or with high disease of severity at presentation because of having gaps in insurance. The other message I think today, as we face times of uncertainty, is that the continuity of maintaining health insurance is very important, not only during therapy, but for disease surveillance after therapy is complete and for monitoring and intervening against late effects which may emerge from the treatment. Next slide. So what should families know at this point? And this will be my last sort of point for today. The current magnitude and impact of changes are uncertain for all of us. Certainly from the questions we received ahead of the webinar, we sense the fear of this uncertainty for families. And as healthcare providers and professionals, we are just waiting and anticipating because we don't know what the impact will be. We know that we don't know what the magnitude will be. We know that the impact will be large for our patients and for our healthcare systems, given what you saw in terms of the number of patients with Medicaid at the time of cancer diagnosis. The changes in policy of coverage and the documents and requirements that are going to be necessary to attain and maintain Medicaid are going to differ by state. So if you're a family who has to move across a state, just remember that. But also know that if you're talking to other families online through chats, et cetera, that I know that are of benefit for childhood cancer parents, that something that applies in one state may not apply in your state. We continue on the medical teams to depend heavily on our social workers who are anticipating the continuation of their work to navigate the application processes for various financial assistance programs beyond Medicaid and including whatever the new Medicaid requirements might be. This includes guidance on filling out forms. It means for you as parents, or for people who are advocates for parents to help them to gather necessary paperwork that your social workers and teams will need to do your Medicaid qualification. It'll be more so important than ever before to meet deadlines and to keep a track of notices that may come to you from Medicaid so that you can ensure timely processing of your application. And importantly, for those who have adolescents and young adults who are going through a cancer experience, to keep updated on changes that impact your child once they are over 18 years of age, or as they complete treatment and enter survivorship. Next slide. So I'll stop there and just emphasize that some of the work that informed my presentation has been sponsored by other funding organizations. But the point that I want to make is that we recognize it's a time of uncertainty and that no childhood cancer center is going to stop therapy or turn away a child with a cancer diagnosis. Every cancer center in the country just has different capacity to absorb the costs. And right now, those uncertainties loom for us on the provider side, just as they do for you on the parent side. So I'll stop there and let the next speaker speak, and we'll be happy to answer questions at the end.
Thank you so much, Sharon. That was, I think, very helpful and very informative. Next, we're going to have Ashley Timmons join us. As Misha mentioned, Ashley is the mom to Ofi, but Ashley also has a background as a medical professional, as a practicing nurse practitioner. So Ashley can share her experiences with the Medicaid system and how her family has utilized Medicaid as a secondary insurance. Ashley?
Hi, everyone. I'm Ashley Timmons. My husband, Shane, and I are parents to two beautiful girls, currently ages 3 and 8 years old. And I really appreciate the opportunity to share our story today and our experience with Medicaid. Our journey with pediatric brain cancer began August 31st, 2023. And after a few months of concerns about our 18 months old's balance and a few doctor's visits and an ENT referral, we finally ended up in the emergency department where imaging revealed a large posterior fossa mass in our daughter Ophie's brain. Our daughter's name is Ophelia, and we refer to her as Ophie. So the next 24 hours, our world was pretty much turned upside down. She had an emergency surgery to debulk her tumor and to stabilize the hydrocephalus or the fluid that was within her brain. And we waited on pathology results, but we knew that we would need to pursue a second opinion to try and get the remaining tumor. So after looking into several different options, Ophie was accepted as a patient at St. Jude, and we moved our family 11 hours away to continue the next leg of our journey. During that time, pathology results revealed a malignant brain tumor called anaplastic ependymoma. And luckily on September 28th, 2023, an amazing neurosurgeon was able to achieve a gross total resection of her remaining tumor. So before this, we were prepared that given the extent of her tumor, we would deal with some challenges after surgery. And after several unsuccessful extubations, Ophie ended up with a tracheostomy and a feeding tube due to her swallowing deficits after surgery. She had a difficult post-op course and required over 100 days in the hospital. And eventually we began proton radiation over the next few months. After completing radiation, we returned home in January 2024, and we spent a week at our home hospital in North Carolina getting set up with a multitude of specialists and beginning the process to get set up with Medicaid, hopefully to get some private duty nursing. So during those several months at St. Jude, we were outpatients some of that time. And so my husband and I were learning how to care for Ophie. And we had not received any nursing help on an outpatient basis during that whole process. So the next few months were filled with calls and emails and long wait periods and dead ends and loose ends and all kinds of stuff. And so even as a nurse practitioner myself, I felt completely overwhelmed a lot of times and sometimes alone in trying to navigate a system that we had just never used before. So I would spend hours on the phone, and lucky we were lucky enough to have resources like my parents that were able to help with Ophie, and family and friends who came to help during that time. We had an amazing pediatrician who went above and beyond to help in every way that she could. She connected me with other parents of medically complex kids who'd been through the same thing. And so we've always had commercial insurance, and we were kind of thrust into this world of Medicaid, all while trying to care for our medically complex toddler, cope with the trauma of the last several months, and then also just kind of maintain some normalcy for our 8-year-old and financially maintain our household. We had a few rough months without nursing care. I had to remain out of work. My husband and I were covering night shifts during that time, since she required continuous oxygen and continuous oxygen monitoring when she slept. We recruited friends and family to go with us to her appointments because Ophie required frequent suctioning of her tracheostomy, so we weren't able to drive ourselves with her for her multiple appointments. And finally, in the spring of 2024, so probably about 3 months it took us, Ophie was approved for Medicaid, and we were able to set up with a nursing agency who provided us with private duty nursing since that time, which she still gets to today. We formed some great relationships with our amazing nurses. They help care for Ophi day in and day out now. This allowed me to return to work. It gave us time to focus, on meeting the needs of our 8-year-old. And it just overall improved our quality of life in our household. We were able to get some rest. So over the next year, Ophi unfortunately suffered a pretty huge physical decline because she suffered from radiation necrosis within her brainstem and multiple other areas in her brain. We completed Avastin treatments, and she's slowly but surely improving. And her scans have continued to show no evidence of disease since we've been out of the hospital. I firmly believe that Medicaid has set us up with the tools to effectively take care of her and ultimately keep her from recurrent admissions. And so we're extremely grateful for our Medicaid services. I think when folks see a family like ours, they may not know that we rely heavily on Medicaid. And that's for us to be able to continue the careers that we love, to continue to remain contributing members of society, and to do our best to raise our family in the difficult circumstances that we've encountered. So as a healthcare provider and a mom to a medically complex brain cancer survivor, I have real concerns about the ability of families who may not have the knowledge or the resources to be able to comply with the changes that are coming to Medicaid. We're concerned about what this can mean for our family, as many other families like ours are too. I'm just super grateful for this opportunity to share Ophi's story. Super grateful for the Pediatric Brain Tumor Foundation and all the individuals who are trying to shine light on the subject today through this webinar. And I definitely look forward to what we can learn about how to be proactive and to be prepared to manage the changes that are coming to Medicaid that will greatly affect families like ours.
Thank you so much, Ashley. I think, what you just said really does underscore why this is so important, because at the heart of this are patient families. And I'm sure many of our attendees today are patient families that are looking for answers as to how this is these new changes are going to affect them. And that leads perfectly into our next speaker. So Marielle Kress is a staffer on the U.S. Senate. She's a health advisor who in previous roles has worked on advocating for better access to healthcare. So Marielle, if you could jump on and explain to our attendees what just passed and what changes could be coming and kind of how it could affect our community.
Thanks so much, Mike. Thank you for having me, and thank you for all of the speakers and the families who took time to be here today. This issue is important to me professionally and also personally. My best friend Rachel is on, and her wonderful son Ollie is living with ATRT. So I do this for him and for all of you. So, I recognize this is an incredibly scary time and there's a lot of uncertainty, and I want to give folks a little bit more information to help them kind of navigate all of the really complex changes that are coming down the pike. And this bill is extremely complex. It's, over 1,000 pages of text that changes the healthcare system in a really fundamental way. And the changes are not limited to Medicaid. They are also related to people who get their health insurance through the ACA marketplaces. So there are a lot of changes to that form of coverage and insurance, as well as ripple effects all across the healthcare system. Because as I'll talk about, these changes take a lot of federal dollars out of the system, and that results in hospitals and other providers not being able to, make ends meet and pay the bills, and therefore jacking up the cost of care for everybody all across the healthcare system, whether you're in Medicaid or not. So this bill really has wide-ranging, deep impacts to the entire healthcare system. So the bill that passed earlier this month cuts $1 trillion from the healthcare system. And enormous portion of that cut comes from the Medicaid program. So around $900 billion are being cut from the Medicaid program over the next 10 years. And a lot of the changes aren't immediate. There are some changes that are immediate, but a lot of them are a couple years down the pike. And so, families may not see immediate impacts on some of these Medicaid changes, but will undoubtedly start seeing them over the next few years as states really need to make some really tough decisions to balance their budgets and address what they see in the next number of years. So I'm going to talk a little bit about some buckets of policies that are included in the bill, and I'm very happy to go into more detail during the question and answer session. So one big bucket of policies that was included in the bill are major financing changes to the healthcare system that will have really big impacts on the way that healthcare is delivered across the country. So as Dr. Castellino mentioned, Medicaid is a state-federal partnership, and states have a certain amount of the funding that they have to put up as for state dollars that aren't federal dollars. And so one of the policies restricts the ability for states to raise and impose provider taxes, which helps them finance their Medicaid programs and will result in a lot fewer federal dollars coming into states. In addition, the bill limits the ability of states to provide what's called state-directed payments. So those are additional payments to hospitals, nursing homes, other providers that allow those entities to provide care. In a lot of rural places, those state-directed payments allow for hospitals to keep their doors open. We know that there are a lot of hospitals across the country that are limiting their service lines. So, cancer treatment may be going away in certain rural areas. We know labor and delivery services are certainly going away in a lot of areas. And this limitation of these payments to healthcare providers is going to have a pretty outsized impact as well, particularly in rural areas. The next bucket of changes in the bill are what we like to call red tape policies. So these are, like Dr. Castellino said, policies that impose additional paperwork and hoops that families have to jump through. And I don't think that the status quo is acceptable. It's already hard enough to enroll in and get and maintain enrollment in health insurance, and particularly Medicaid. And this bill will unfortunately make it harder to do that. So one of the policies that lives in this bucket of red tape policies is that for a certain group of Medicaid beneficiaries, those are the expansion population, so generally adults, but there are many people with disabilities that fall into the expansion population. Instead of recertifying their eligibility for Medicaid on a yearly basis, they are now going to have to recertify their eligibility for Medicaid on a 6-month basis. And we know that creating additional hoops for people to jump through and paperwork means that people needlessly lose their insurance and churn and don't get the care that they need, and have to jump through those hoops to get back on. And we know that a lot of folks don't even realize that they've lost Medicaid until they show up at a doctor's office or they get a bill from a service provider that hasn't been covered by Medicaid. Another really big policy that was included in this bill are what we like to call work reporting requirements, which essentially force people to prove that they are either working or caregiving or going to school or all of the things that people do on a daily basis. So we know that the vast majority of people who have Medicaid are either working full or part-time, or are caregivers, or are in school, or face other circumstances that prevent them from working, like a chronic healthcare condition. And this policy forces them to prove that, and produce documentation to prove that. And again, this is for the expansion population, but we know that there are all kinds of folks who qualify for Medicaid through the expansion. And we also know that if an individual, like a parent who's in the expansion population, loses their coverage, it's much more likely for a child in that family to also lose their coverage, because that parent is not being reminded to renew their own coverage and may forget to renew a child. So it really just puts up more bureaucratic barriers. And we know from the data that this does not produce additional people in the workforce. It's frankly the opposite, putting up barriers and preventing people from staying in their health insurance. It prevents people from working. And Ashley so eloquently talked about how Medicaid allows folks to be back in the workforce and get the services that they need to do that. There are also a lot of wonky rules that the bill repeals, and a lot of the policies that are included in those rules also made getting and keeping health insurance through Medicaid easier. And so a lot of those pieces of those rules are now being repealed as well. So for individuals who are both eligible for Medicaid and Medicare, the previous administration promulgated a rule that basically allowed for a much easier process to enroll Medicaid beneficiaries to get their Medicare premiums paid for. And those policies have been repealed through the reconciliation bill. Another bucket of policies included in this bill are what I like to think of as sort of related to access, and access to care. So one of those is the imposition of additional out-of-pocket cost sharing on individuals. And again, this is for the population that got eligibility through the Affordable Care Act, the expansion population. But I think we'll have also ripple effects across the healthcare system. And these are cost sharing amounts up to $35, which, as you all know, really adds up over time. Another access issue relates to the exclusion of Planned Parenthood from the Medicaid program. We know that Planned Parenthood provides all different kinds of services, may be the only service provider in a person's area. And we anticipate that a number of the clinics will close because of this policy. The bill also restricts Medicaid eligibility for certain immigrant populations, including asylees and refugees. So there will be fewer individuals who receive Medicaid because of their immigration status, even though they're legally in this country. And then finally, another policy I'd like to highlight is retroactive coverage. So when individuals have medical bills before they get enrolled in the Medicaid program, Medicaid used to pay for those medical bills up to 3 months before enrollment in the program, and now that time frame is being reduced. So this is really a cost shift overall to states, and then a cost shift to families and individuals. And that's kind of the bill's theme in a nutshell. So in terms of the impact, and Dr. Castellino talked a little bit about this, I think we are all trying to figure out, the projections and the analyses of what will happen, and we have that information at a high level. Some folks may be familiar with the KFF organization that does a lot of great data and research, and they have data looking at the sort of impact across the 50 states by state, how much federal dollars will be reduced by state. But that doesn't really tell us anything about the real specific impacts that will happen over the next 10 years because of this bill. And that's because we know that there will be hundreds of billions of dollars fewer going to states from the federal government, but states have to make certain choices to be able to fill those budget gaps. And they really only have a few options at their fingertips to do that. And the three most common in the context of Medicaid is, first, they often resort to reducing rates to providers. So we know that the Medicaid program pays generally less than Medicare or commercial insurance, and budget deficits at the state level force states to reduce those reimbursements even further, which makes providers less likely to participate in the Medicaid program. Another option that states have are reducing the types of services that are available to individuals. And so, history tells us that when states have budget deficits, they choose to eliminate some optional services. So there are services that states must provide by federal law, and there are some services that are optional. And the home and community-based services that a lot of families on this call use are actually optional services and are able to have caps and waiting lists. And I'm sure many folks here are very familiar with that. And they are able to reduce the number of hours, for example, that families will get, or reduce the number of slots in those waiver programs. And that's something that we have seen in the past happen when states are facing budget deficits. And then they also, have the lever of reducing eligibility as well. So they may decide to, not continue a particular program for a particular group of people, or reduce the income eligibility level if they are higher than the federal requirement. So, not that many choices for states, and all of them have really critical impacts on individuals and people who are getting services through the program. And we don't know what those choices are going to be yet. But one thing that, I am working on, and colleagues that I work with are working on, is really tracking that and trying to understand and quantify what those choices are. And seeing what state legislators are doing to make those choices. So that leads me to my last point, which is, where do we go from here? What do we do? And I imagine, and I feel this way too, that this is a moment of real uncertainty and hopelessness, given just how much is likely to change in the healthcare system. But I think there are a couple things that folks can do to really communicate what Medicaid means to them, and try to influence and advocate for some of those changes at the state level to not impact the services that folks rely on who are on this call. So I think, primarily connecting with your state legislator, your state senator, your state congressperson, because those are the folks who are going to go during the legislative sessions and make the decisions about how the state is spending their money. So really creating those relationships, if you don't have them already, is really critical. And also with state health officials. So the Medicaid director's office, the Secretary of Health's office at the governor level, you should reach out to them and tell them about the importance of Medicaid to you and the waiver services and the other services that you are accessing. And then we're about to be on recess here on Capitol Hill. And so all of the members of Congress go home for the entire month of August. And they're home all throughout the year at different points. And I think it's really critical for people to go to congressional town halls, for people to ask for meetings with their members of Congress, whether that's in the district that you live or in DC. We need to tell members of Congress what the bill will mean for families. They need to hear it from us, and they need to be accountable for the votes that they took to pass this bill. And then finally, in all of this, all of the sort of other calls to action that I mentioned are underpinned by the last thing I'll say, which is just to tell your story. And Ashley just did an incredibly beautiful job of doing that and illustrate what this means for families all across the country, and to find opportunities for advocacy. So I just came from a press conference where we had a number of families who told their stories and made their children be seen and heard. And that is the most powerful advocacy tool that we have. So I really appreciate you all being here, and I'm happy to help support and answer any questions.
Great. Thank you so much, Marielle. We are going to now, I'm going to throw it over to Misha, who's going to intro our Q&A.
Yeah, thank you to all exceptional speakers. If you don't mind, all the speakers, please turn on your cameras, because there are going to be multiple questions that I would like all of you to address as you seem fit. We've received in our registration over 75 different questions. We'll try to go through as many as we can, but please keep putting your questions in live in the Q&A sessions. We're going to start with some of the ones that are already put in the live session. The first one is, if the rectification happens, recertification happens every 6 months for adults, would adults with children also have to do the recertification every 6 months? I think, Marielle, do you want to take this question?
Sure. That is not what is supposed to happen. So it should only be the adult that qualifies for Medicaid on the basis of being in the expansion group. And obviously eligibility is super complicated, and a lot of folks don't even know, what group they're in. Most people don't know that. Some people don't even know that they have Medicaid, because there are different names in every state. There are different names for waivers in every state. And a lot of folks are enrolled in health plans that kind of look just like any other type of health insurance. So that is not what is supposed to happen. Children should not be redetermined every 6 months. But, I think you all are really amazing and vigilant, and you will need to stay that way, because I think that this is this was a rushed, behind closed doors process that was not a process that was really thoughtful about what the situation is on the ground and what people experience. And states are going to have to implement these policies extremely quickly, and I think they're going to make mistakes. And so people need to really be vigilant if they're seeing that, inadvertently kids are experiencing these changes when they shouldn't be.
Thank you. The next question is, who exactly is the expansion population, and does that vary by state?
Or yeah, so historically, before the Affordable Care Act passed in 2010, and then the expansion went into effect in 2014, the Medicaid program was really focused on providing coverage to groups of individuals based on who they were. So it was children, both with incomes under a certain level, and then also folks who are qualifying for these waiver programs, people with disabilities who had SSI, parents who had really very, very low incomes, and people over 65. Basically what the ACA did was create sort of an income threshold for adults, regardless of whether they had children or not. So if you are a person and you live in a state and you meet all of the eligibility requirements, including your income is below a certain level, then you're eligible. You don't have to fit into one of these other categories of people. And as Dr. Castellino said, 40 states have taken up the expansion, and there are 10 states that have not. And you heard me talk about a lot of these policies are directed at the expansion population and will disproportionately impact the expansion population. But again, fewer federal dollars coming into states because of these policies affecting the expansion population are going to have ripple effects across the entire program and impact all aspects of the program and people's ability to access services through other avenues in the program.
Thank you. Dr. Castellino, do you have any comments to make on this as a provider perspective?
About the expansion or about
about the expansion population and how does it affect when they come into the clinic?
Yeah, I mean, from a provider perspective, I don't know that during therapy that it affects care, attendance, delivery, services, like sometimes transportation services, et cetera, during the coverage of those during therapy. I think what I worry about is after therapy is done, that those things are at risk of falling off anyway. And those are still important times for kids, even if they don't have any acute side effects at the completion of therapy. They still need to be followed for risk of relapse. Overall, childhood cancer patients are doing much better, and the relapse rates are lower, but there still is that risk, and then the risk of side effects can actually slowly emerge over decades after. So I think that's where I am concerned about these changes. And then going back to the eligibility, depending on what bucket you qualified for during therapy, those can really dramatically change. And as I mentioned earlier, especially if your child was treated at 17, and then all of a sudden that by the end of therapy they're 18, like what happens to them as an adult? And that varies from state to state. So we really worry about those adolescent, young adult age patients who have already been on the fringe, for many reasons, not just because of the fact that they're transitioning out of their parents' homes and don't have somebody to kind of watch out. I mean, these things are complicated for like full-blown adults for me to understand, like all the paperwork, et cetera. But now you have an 18-year-old, and you have a 18-year-old who might have some cognitive dysfunction from having had therapy or things like that, and also don't have a parent there to remind them about things. So I think those are the groups that I worry about, the adolescents and young adults. So I think we've always felt some confidence that during therapy things are, very well followed, because even our social workers, et cetera, they are very vigilant and dedicated. And it's not that they're not once people get into the survivor phase, but those patients disappear from weekly contact with the clinic. And so I think there's more risk at that point.
Thank you, Sharon. I did want to highlight one of the questions that was posted in here by Sarva. Marielle, maybe you could talk a little bit about her question about the when the changes will take effect. But before that, I did want to address, Sarva, you talked about alternative coverage options or state-based resources. Like there are in certain states, and it's worth doing your due diligence and research and talking to social workers or your care team or nonprofit partners about that. So a good example of this is Child Health Plus in New York, which is a low cost alternative for low income patients that aren't eligible for Medicaid. There's the Catastrophic Financial Relief Fund in New Jersey. Like both of those are examples of resources that are available on the state level for patient families. So if you are feeling overwhelmed and you can't do that research yourself, you can reach out to your care team or to local nonprofits that have family support teams. We have our family support team here, but also there are many CAC2 members that have a family support team and would be willing to help you. So just, I think the overall message here is to reach out to organizations and care teams and members that are willing to help you through navigate through this and surface resources.
Yeah, I think in addition to locally, you know, for different disease groups, there tend to be advocacy and foundation. So I've seen and treated every type of cancer in children during my career, but right now I do a lot more with leukemia and lymphoma. So there's like the Lymphoma Research Foundation, the Leukemia and Lymphoma Society. Locally, there's Rally in certain states who, you know, have more attention to families in their region. And so, you know, social workers tend to keep abreast of those programs, but they're also changing. Each of these programs, you know, some start out as a research program and then add a family support component because of recognizing that, you know, very important need. So, you know, it probably feels overwhelming for families, but I think it's going to be a multi-pronged approach of keeping your eye on where the resources are.
And just, this is a good opportunity to also shout out CAC2. So one of the things that CAC2 does very well is it brings together other organizations throughout the country, both big and small, to talk about how we can better support folks on advocacy, but also stuff like family support. So just know too, for patient families that are wondering, you know, these organizations are out there talking to one another and constantly talking about how we can improve the way that we serve families. But for those patient family teams or nonprofit partners or hospital partners that want to be involved in those discussions, come to CAC2 and get involved and talk with the other family support teams and learn from one another.
Can I ask Marielle a question? What do you anticipate? I mean, certainly, even if this bill or the components of it were arrested in 4 years, there are going to be downstream effects that are hard to reverse and walk back in a short timeline. But is there a potential right now, since things will have a staged approach, for certain parts of this to be terminated or disrupted now that it was approved? Or what will that look like for families?
Yeah, at the risk of becoming too political, I'll try to answer that question. I think, you know, like I said, so much of this is sort of intertwined with itself. So even sort of reversing a few aspects of the bill will still have really big ripple effects across the healthcare system. You know, Capitol Hill has some really arcane rules and challenges to passing legislation. And so the fact that this bill just cut $1 trillion and saved the federal government $1 trillion means that restoring those cuts would require the Hill to pay for $1 trillion of Medicaid spending over the next 10 years. So I think it's just, it's going to be really challenging to see a way to kind of reverse the entire enchilada. And on top of that, I mean, the administration is making so many of these changes administratively as well. So for example, we just saw last week, the administration came out with guidance to states that a number of states actually have gone above and beyond the law and allowed for states to not force or require families to recertify their Medicaid coverage every year for children. So for example, the center that I work for is from Oregon. Their state does not require redetermination of Medicaid eligibility until the child turns 6, which is so helpful to families. And so there's a lot that's happening sort of administratively as well. I think those are the things that are much easier to reverse if there is a different administration. But right now, one party controls all three sort of, both the House and the Senate and the administration, and I don't see sort of in the next foreseeable future the ability to overturn some of these things. And the financing things are really the the things that sort of require an act of Congress to overturn. So yeah, it's a challenging picture.
Marielle, could you real quick just also give us an overview of these changes that are coming, what the timeline could look like?
Yeah. So immediately can be no new provider taxes or state-directed payments that states can effectuate. So like immediately that hampers states' ability to finance their share of the Medicaid program. So that's an immediate impact. Later down the road, starting in 2028, only expansion states will actually have those provider taxes that exist currently phased down, which just has broader impact on the state's ability to finance the Medicaid program. But that's out in 2028. The work reporting requirement policy goes into effect at the end of 2026. But states can apply to the federal government to actually go earlier than that. So we're going to see some states doing that and rolling that out over the next year or two. The rural moratoriums that I mentioned that help people who have Medicare pay for their premiums, that's immediate. That will not go into effect. Like those policies were set to be effectuated next year. They will not now. Yeah, so Planned Parenthood is out of the Medicaid program now as we speak. There's some litigation there, but so there are some, and then of course, and I know this is a webinar about Medicaid, but ACA coverage is really sort of inextricably tied up with Medicaid, and all of the marketplace policies are going into effect now and will impact people's premium rates for this year. So people are going to start seeing, if they are covered, if they, are employed by a small business or they buy health insurance on the marketplace themselves, they're going to see premium impacts immediately. And then some of the sort of other policies that I talked about in terms of like adults having to reapply for coverage every 6 months, that's 2027. I think retroactive coverage is also in 2027, and the immigration status policies, I think, are also in 2027. But I actually have a handy timeline that I can share, Mike, and you can share with others.
That'd be great. Thank you. I do want to, before we kind of wrap things up in the next 10 minutes, get Ashley's perspective from a patient family's perspective. What resources did you utilize that you found helpful, and what would your advice be to care teams or family support teams on how they can help families navigate through this process?
I think a lot of it was just kind of research on my own part and just having some, foundational knowledge about at least where to begin. I think we found a lot of help through, our social workers, probably, at our home hospital, and then also through St. Jude, just because we were there for so long. The hard part with St. Jude, or for other families who have to seek care out of state, which is pretty common with cancer treatment. A lot of them don't know, how to help you in your home state because they don't know the resources that are available there. We actually found one of our insurance company, our commercial insurance company. There was a case manager that was assigned to Ovi's case, and she reached out and was helpful about telling me, to apply for Medicaid and different things. So I actually found that she was pretty helpful as well. I've reached out to we have, and I'm not sure if this is state specific or if everyone has one, but the Medicaid Ombudsman, I think I'm saying that right. They were really helpful. Like, once I found out about them, it's kind of an advocate for, to make sure that you're getting what you need. We reached out to Tom Tillis 2 or 3 different times, and they were extremely helpful. So I've pretty much used every resource that there was to get Opie what she needed.
Actually, can you say where would they find these resources for parents who are not, having a medical background like yourself?
So I Googled
that is newly diagnosed, right? Like a parent that has a kid that's newly diagnosed.
I would say, definitely if you have a good relationship with your pediatrician, that's a really good place to start. And some, are not as knowledgeable about, cancer care and things like that nature. Luckily, our pediatrician is really tied into our local hospital and has lots of resources there. And Opie has a ton of specialists, so we're highly linked up to our hospital. So I think probably a good place to start would just be the initial hospital, where you're starting treatment at, and then you just kind of build from there. And I found a lot of resources too from other parents that I got hooked up with, whether it be like social media groups and things of that nature. So it's just, there was not really one specific place but I think, the place where it kind of all started from is just where we initially got diagnosed, initially started our treatment, and then just kind of built on it from there.
Yeah, and I'll just add a little bit too. There in every state, there are organizations called family to family health information centers. Those can be helpful. Those are staffed by families who have walked this path before and are helping families who are maybe newly on this path. And then there are other, advocacy or patient support state level organizations as well that are skilled in navigating these really complex systems.
Yeah, I think that's a great point. There are so many of the folks that are on this call today that have a community or resources available to patient families. This is not just patient families on this call. These are social workers and nonprofit partners that are out there and willing to help and may already have this information available for you. So I think what we want to underscore for the patient families that are on this call is we are out here to help. Our family support teams stand ready to help you. And even if our organization can't help you answer a question or find something, we have wonderful mission partners that we work with that should be able to get you what you need. So we have a large, wonderful community that likes to collaborate with one another.
Yeah, along those lines, as Mike previously said, right, CAC2 is also national. So we have representations of organizations from each state. So if you can't find a resource and you need something, please lean on to the CAC2 community. And we have local nonprofits within that states that can help, which usually these foundations are built by parents that have walked through these these steps. So we've been through these medical challenges and stuff. So reach out, and I'm sure, as Mike said, if we don't know, we'll find somebody who does know, and we can get you the answer in that aspect. In the last 6 or 7 minutes, I have just one question that I think is interesting, and I don't know if Marielle, you could shine some light on this. Is that Medicaid, even out-of-state Medicaid challenge, even in the previous administration, was very difficult, right? We had Accelerating Kids Access to Care Act. How does that change? Now that most of the Medicaid is state dependent, and now if you have to seek clinical trials outside, how does that scenario change in this current landscape?
Yeah. So, states all have policy. There are federal rules and guidance and policies about seeking out of state care. And so states, have a process to do that. And that is not going to change. The Accelerating Kids Access to Care Act was a big priority on both sides of the aisle last Congress, and was actually included in the funding bill to fund the federal government at the end of 2024. And unfortunately, that did not make it across the finish line, but was, a real priority for a lot of folks here. And what I think folks know what that bill does, but it basically just makes it easier for providers to be participating in other state Medicaid programs. And I think, again, the impact is not known, like the specific impacts of this bill are not fully known, but I think just like the availability of services and the ability for states to cover those services and provide that care is just going to be harder for states. And so I can't answer specifically how that will play out in the next number of years, but I just anticipate the challenges that people are facing are just going to be more concentrated and more challenging than they even have been, which is unacceptable already. So sorry to not have a more satisfying answer.
Well, to build off of that too, a good point here is that there is good legislation that's still out there that has not crossed that finish line that we can advocate on behalf of over the next few months. As we leave, Marielle, is there anything that you think it'd be important for advocates to do over the next few months towards the end of the year? Is there anything that they could be advocating specifically for that could really help our community?
Yeah. So I think, again, like going and making those relationships at the state and local level with lawmakers is really important, and talking about the services that you use through Medicaid. I think, my boss today introduced a full repeal bill. So there's a bill out there now to just completely reverse every single cut that was included in the bill. And I will pass along the name of that bill and the number, and folks can advocate for that, because we need to start over here. And like I said, the status quo is not acceptable, but these cuts are even more unacceptable for families and kids, and are gonna have really devastating consequences. So, and again, and like Mike said, accelerating kids still not over the finish line. So please feel free to keep advocating for that as well.
Thank you, Marielle. And I think that'll be our last question. But if there are any questions that you had that weren't answered today, we will put up a QR code here for a survey, and you can include any questions there. We will get back to you. But one thing I did want to say is if you want to get involved in the advocacy side of things, please reach out to us, email me. My email address is mhenry@curethekids.org to learn how you can work on either the state or the federal level. And then, of course, if you need help, please reach out to us and our family support team if you need connection to resources or want to learn more about how you can help your family and advocate on their behalf. Please reach out to family support at curethekids.org. I just want to thank our speakers again. I hope this was helpful for both our patient families and our mission partners that attended here. Again, please reach out to us if you have questions or if you want to work with us on making sure that these issues are surfaced not only for our families, but also for decision makers and lawmakers. Thank you so much. Have a great afternoon. Speakers, thank you so much for your time.
Thanks, Mike.
Thank you, everybody.